if for whatever reason you do need to clean it, the way you do it is you get some syringes, you get some normal saline, just the stuff out of the drawers used for cannulas as well, and you gently irrigate the wound. So what I tend to do is grab, say, a 20 ml syringe, and then you can get a cannula. You can take the needle out, so you've just got the actual plastic cannula end, and then attach that. And you can make it like a relatively big size if you want, like a 16 or 18 gauge, and then just gently spray that on the wound slowly, okay? Don't rub it, because it will aggravate the wound and you might actually do damage to the underlying tissue. And don't immerse it at all, because then you'll actually get the water that gets in there and it can cause dehiscence of the wound, which is horrible, and maceration of the skin. Antibiotics, they shouldn't be routinely used for post-operative wounds. They might sometimes get used for the actual procedure itself, or at least that's the argument that you get given. Like in orthopedics, everyone gets cefazolin for 3 doses afterwards. The cardiac surge guys tend to do it as well. But a wound itself doesn't need antibiotics unless there's a reason for the wound to need antibiotics. Okay, so it's not sort of normal standard par for the course, everyone gets antis. Dressings. So ideally, what a dressing is supposed to do is actually keep the environment a little bit moist to promote wound healing a bit further. It's supposed to remove excessive exudate. It's supposed to provide a great barrier externally to any sort of external pathogens and to allow fluid to move without actually contaminating. And of course, it should be able to stick to the skin to provide all of that. Those are sort of the gold standards of any sort of wound dressing. So I know that some people I've heard before, like you put dry dressings on moist wounds and moist dressings on dry wounds and that sort of thing. The idea is just that you're trying to maintain an environment that is neither too dry nor too wet to allow that optimum sort of level of healing to occur. There are lots of ways to dress wounds, and everyone has their own opinion on how to dress a wound, on what product you're supposed to use, and there's 100 products out there. So just get used to whatever your registrar uses, or your consultant, okay? There's really no other way around it. Having said that, there are sort of generally some broad different types of wound management stuff to look at. And essentially, you can probably dumb it all down to protective versus autolytic debridement. Yeah, the two in the middle, the antimicrobial and the absorbent ones, aren't really used too often unless it's one of the wound care nurses that decides that this is the new cool thing to do, and so be it. But you either go protective, which is where you get gauze, and you put it on there, and you might have a bit of saline on there, or you might have nothing, so be it, and it sticks around. Or you go with autolytic debridement, which is like the nets, those gel things, those other sort of extra things. And what those are actually useful for is when you have a wound that hasn't been primary closed and has undergone secondary closure, and it helps essentially get rid of some of the necrotic and the dead tissue. So it acts as a debriding tool, but a medical rather than a surgical debriding tool. Okay? And that just helps with the wound to heal. More often than not, protective, of course. Okay? And so this is essentially what you'll be asked to look at most of the time, is complications. And the two complications are that the wound isn't working and doing what it's supposed to, so it's fallen apart, or that it's gotten infected with something. So when you look for an infection, someone thinks it's a wound. I mean, if someone is ever SIRS positive and they've had surgery, you have to sort of consider that the wound or whatever's inside could be the cause. But if someone says, oh, I think that wound looks yuck, can you have a look? Go and have a look at the patient and take the opinion that you're looking for a septic patient. So look for a SIRS response. And then have a look at the wound and have a look for things like purulent discharge. And you will know when you see like purulent discharge, because it absolutely stinks. It's foul smelling and it's disgusting. Have a look at the wound edges. See if they look like they're actually still approximated really well and they've just come out of theatre, or if it looks like they're coming apart in a couple of areas. Feel around the wound. So not just sort of around the edges of the wound, but feel right up to the edges, deep underneath, and see if there's any pockets or any collections, or if anything actually comes up through the wound itself when you press. And I guess the note here, and this is why you have to remember that that inflammatory phase is the first thing and it's part of normal healing, is because you'll see every wound that you will see that people will generally ask about is going to be inflamed. Otherwise, they probably don't ask about it. Okay? So immediately post-op, you expect them to be inflamed. If they don't have any other malicious features, don't go thinking that it's an infected wound just because someone said so. Okay? So they'll look pretty big, they'll look red, the redness will be quite a margin sometimes around the incision, depending also on how much tension, like the big laparotomy scars can have a couple of centimetres either side of erythema around them afterwards, okay? If it's not tracking across half their belly, it's probably not cellulitis. Now, having said all that, if you decide, I think I've got an infected wound, then you have to take swabs of the wound. You can take swabs of the superficial aspect of the wound if there's something that's coming out. The problem is that when you do that, you're likely to get skin commensals. Now, also, some might argue that's okay because skin commensals are the common things that actually aggravate a wound, and that's true. But potentially the infection is coming from whatever was underneath the wound that they needed to get into. So ideally, you can take one from the surface if there's anything on there, and if you can, you try and get one of the little swabs inside the actual wound itself without, as much as possible, touching the actual wound edges. That way you get a good idea of if there's anything growing inside and what it is. Okay? And label them both so then the path lab knows which one's which. You start antibiotics relatively early, and in terms of what antibiotics, you're going to be covering your Staph aureus is the most common one. Now, whether or not they say that it's an MRSA or not is obviously dependent on the patient, and they generally will do swabs of that and send it off. And it also depends on the surgery. So most general surgical procedures will get anaerobic cover as well. Most cardiothoracics will just get broad empiric cover because they don't want anything underneath being damaged. They're very precious about it, but fair enough. And whatever you do it starts broad, and the moment you get sensitivities back, you narrow it down. And that's sort of your job. So the problem is that if you leave it to the registrars to check, first of all, surgical registrars won't ever check. They'll wait for ID to say something if there's an ID service. And if they're actually being really diligent and they do check, it'll be the next morning or the next night. And it can be a long time, sometimes 24 hours between them checking. So you ideally, as the intern, should check. At the start of your shift, maybe a bit through your shift, do a quick wound round or path round, and then at the end of your shift as well, and hand it over. So if you've got interns during the day and overnight that are sort of checking that stuff, or residents overnight, then you've got a good chance of picking up early. Okay? So that's the infection side, and of course then there's potential for surgical debridement, but that's not something you necessarily worry about. The wound dehiscence. So more often than not, if it's a small wound, like port wounds or something for the gen surge when they do laparoscopic things, or arthroscopic wounds for ortho, primary closure is generally going to be okay if it's dehisced. So it might sometimes just be the suture that fell through, it might be the wound edge was a tiny bit macerated but was in fact otherwise okay, and the reg will have a look and maybe chuck another suture through it and be fine. Larger wounds will generally be treated by secondary closure straight away. So very few larger wounds, unless they were a really good one in the first place, will get taken back and then re-primarily closed. So that's when you're likely to get a wound that comes back open with some form of dressing on top. Okay? And the only other final tip and thing to remember is that hyperglycemia blunts the inflammatory response. And everyone that's in hospital, pretty much, has diabetes. So post-op, make sure that you're getting the nurses to check the blood sugar level relatively frequently, just because it's worth staying on top of it. If you don't keep them in a really tight control range, they've got a higher risk of getting the infections and of having wound dehiscence. And the first few days are quite critical. Okay, so try and stay on top of it then. So a few people asked about drain tubes. There's not really much to know about drain tubes. So some of the broad rules I can tell you is that every surgeon has their own particular way that they treat drain tubes. So all you have to remember is that unless you're told by the surgeon or the registrar that's pretty much acting on behalf of the surgeon, you don't muck around with the pressure, you don't muck around with the drainage bag, and you definitely never remove the drain tube. If there's any confusion, don't remove it. Once it's removed, it can't go back in. Okay? There's the difference of active versus passive drains. So active being that you've got some form of active suction on it, passive being that it's freely draining by itself into a bag or not. That's not necessarily defined by those two. Open and close is what defines whether it's in a system, a collecting system, or whether it's just open to gauze. The only ones that you'll really see that are open to gauze are Penrose drains. We'll talk about those in a minute. So most of the time you're going to have closed drains, and they'll probably be active to begin with, so they'll have a suction, some form of suction on them rather than just a passive thing.
So ones that are set, like if it's written that they need to be aspirated every 4 hours or something, that's just a passive drain that's then...
It could be passive, or it could still be, I guess no, you wouldn't be aspirating if it's on suction, so yeah, it'd be passive. So infection risks for all drain tubes, at around day 3 or 4, the infection risk starts to multiply to a ridiculous sort of level. It's not to say drain tubes won't stay in. You'll see people that have them in for a longer period of time. But generally, drain tubes aren't meant to be in there that long. So if you're getting to day 3 or 4 with a drain tube still in, then it should be a warning sign to you that this is someone you might have to look at a bit more frequently, or check their drains a little bit more and see what's going on. Okay? And consider it obviously as a source for any SIRS positive patient. That's, I guess, a given. They can be really painful, not just to insert initially. So obviously most will be done in theatre. The exceptions being, say, ICCs that are done in ED. But even to remove or just having there, they can be quite painful. Okay, so it is really important to analgese these patients adequately, and this is with all patients, obviously, but especially these ones. Anyone that's had drain tubes in is probably going to be relatively immobile. If they're relatively immobile, then they're not going to be breathing properly, and if they're not breathing properly because they're immobile and they're in pain, then they're going to get some form of atelectasis and pneumonia, and then they're in real trouble. So these are the people that you want to have their analgesia good enough that they can essentially take big breaths, cough, and move around as much as they are able to with their post-operative instructions without any pain causing limitations. What else have we got? Removal of drains. So ortho, there's not really much evidence for them having drains in the first place for most arthroscopic procedures. However, they always come back with a drain. You'll find they get removed very quickly as well. So within a day, they often get removed. Cardiothoracic and gen surge, which are the more common drains that you'll see a lot of, generally they have mils per hour or mils per day drainage sort of targets. Generally speaking, if you have less than 10 mils an hour, that's a pretty good sort of remove the drain criteria. Okay. And then the types of drains. So these are sort of the, I guess, the 4 types of drains that you'll see. And I put a vac dressing down there, but I'll explain, I guess, why. ICCs/SCCs, so those you'll see in the cardiac versus thoracic patients. So thoracics will generally have intercostal drains. They do a thoracotomy and they just pop a drain in there. Cardiac often actually have subcostal drains that go into the mediastinum and into either pleural space. Everyone gets really confused about wet suction, dry suction, gravity or suction, all that sort of stuff. Chest drains are actually quite simple. They've got 3 chambers. One chamber is where all the crap drains into, so any fluid that gets removed. Attached to that chamber is where you have your underwater suction sort of device, and that just acts as a one-way valve to stop air from going back into the person. Then the 3rd chamber is where you have your pressure device, and that determines how much negative pressure you want the whole system to be under. The idea of wet versus dry drainage is related to that last chamber. So every chamber, every drainage set has water in it in the middle chamber in that underwater sort of level. The wet versus dry is what gives you how much suction you're on. So sometimes in the wet scenario, that's when they've got one tube that's full of water and it will be somewhere between 20 and 40 centimetres. And the reason of that is because they want 20 to 40 centimetres of suction. So they put it up to that 20 centimetres and there'll be a line on it. Then you turn suction on the wall until it just starts to bubble through. Essentially what's happening is the suction is above the level of the water. It's sucking out the air in that gap. And there's another long tube, a vent, that's connected to the outside and to the bottom of the water. So when that suction is enough to be able to drag air through the vent and then bubble through the actual water column itself, you know you've got your 20 centimetres of negative pressure that's been applied. So that's how the old water suction ones work. If you want more pressure, they pour more water in and then you have a 30 centimetre column to go over. And that's why when they put drains onto suction, you turn the suction on the wall and you see it just gently bubbling up through that solution. You don't want it bubbling like going crazy because it's not doing anything. All it's doing is bringing lots of air in there, but it's not under no more pressure. So just bubbling up and then you know you've got enough. The dry version, that wet chamber's gone. It's just a one-way valve that essentially they can dial up and say, make it this much suction. Same concept though, okay? And then suction versus gravity. The way that these drains tend to progress is everyone comes out on suction of some sort. Once they have suction under control and there's no obvious air leaks and they're quite happy with how the drain's progressing, they'll put it just to a gravity base, so no extra sort of suction negative pressure. Once they're doing well with just gravity as the suction device, for want of a better term. They clamp the drain and see how the patient goes. If after clamping the drain there's nothing else, then they remove. Okay? And generally 4-hour post-chest x-ray for pneumothoraces or recurrent effusions if that was the initial reason to go in there. Most of the post-op surge patients will be fine and pneumothorax is the one to look for. The only comments I can give you is you're supposed to with every chest x-ray, often fair enough, but in this in particular, make sure when you look at them, you actively look for a pneumothorax. Don't just look at the chest x-ray and try and get a general picture like you do with everything else. Actively look, work out where the tubes were and look for a pneumothorax. Otherwise you miss it. And they get missed by consultants all the time. And then the radiographer, when they get the report a day later, will be like, why is this guy sitting on the ward with a massive pneumothorax? And you're wondering why he wasn't breathing properly. Okay, so check. JP drains, Jackson Pratt drains, are then pretty much all of the other drains that you see, which are the surgical drains, and they're the ones that small tubes and they've got generally some form of suction device. A lot of them are sort of circular suction devices that you can squeeze shut, and it's got 2 valves, one above, one below, and there's a drainage bag underneath. And those ones, they're closed drains. They've got those 3 sort of elements. Don't muck around with them. The nurses will have it on and off suction as they see fit. You can have no suction on them and have it free draining. But generally, they will just take that out anyway when it gets to that stage because they're not really there for huge amounts of fluid. They're more there just for that little bit of post-operative care. Penrose drains are probably the only open drain that you'll see commonly. They're used in a lot of gen surge procedures like pilonidal, abscesses, anything around that area. They're also used thyroids quite a lot, so and some ENT procedures. And they're basically really flimsy, like rubber tubes. They're quite wide as well, like they're almost 2 or 3 times the width of a straw. And they really look like just rubber. Like when they sit outside, they close shut on themselves. So they're not like an actual solid tube. They're like a really flimsy, like rubber band style material tube, okay? Those are open and you just put gauze underneath it and it just passively drains out. Onto the gauze, you change the gauze. The only things to watch about those is that I've seen a few that don't have it. I'm not sure if it's a new trend, but what they should all have is some sort of needle or sterile thing at the end, because essentially they sit in a very small wound, and because of some of the areas where they do sit, there's the potential for them to fall back into the wound. So you put like a pin there so that you don't lose the drain. Okay? And essentially when it comes to taking it out, you just grab it and pull, and it just squeezes its way out of the wound. Vac dressings are the last one, and that's sort of vacuum-assisted closure devices. They'll basically be used for a lot of your secondary closures or when you've got patients that are going back to theatre every couple of days for either washouts or some sort of thing like that. And that's just a big dressing that sits over the top of any sort of wound and is connected to a suction device. There are a couple of different ones, depending on which hospital. They've got different companies. You don't necessarily have to know much about them, but just to be aware that they exist. And they're just these really, really big, like styrofoam-like looking things that will sit inside a wound and have a tube that's connected. It's like a little pump device that sits at the end of the bed. Okay.
Is that sucking like?
Yeah, so it's essentially acting like a combination of a drain and a dressing, because what you've got is, say, they're often using laparotomy wounds, so taking them back for recurrent washouts, instead of re-incising and then closing and re-incising and closing, they leave the wound open, so you've got this big elliptical wound in the middle of the belly that looks like it's packed with styrofoam. It's then packed over with a lot of, like a clear sort of tape that's part of the dressing. The tube comes out of the middle, they turn on the negative pressure, and it sort of closes it together a little bit. It sucks all in like a, I can't even think of what it looks like, but it looks like styrofoam really. But it essentially causes negative pressure to try and drain any other collection inside minimally, but to give it some negative pressure drainage. And it's not effective as a drain per se.
How long do they stay on for a back dressing?
Until they decide to either do proper primary or secondary closure of a wound. So again, it'll probably be until they, with laparotomies, they'll tend to try and do a primary closure. So as they keep closing and closing and closing. So analgesia was another one that a few people asked about. So generically, the different types of or classes of analgesia, I know it's, I guess everyone's been over this a fair bit, but you've got your non-opioid analgesics, which is paracetamol. Your NSAIDs, which is ibuprofen. Don't really use COX-2 inhibitors anymore unless there's a good reason. It's not routine use because it's got an increased risk of strokes and MIs. Your weak opioids are codeine and tramadol. The codeine you either get with paracetamol, so Panadeine Fort, or tramadol you can give as a separate medication. From the weak opioids, you then get into the strong opioids, which is pretty much everything else that you've heard of: oxycodone, morphine, fentanyl, hydromorphone, buprenorphine, those sorts of things. The common ones you see are obviously the first three, and maybe the last one, like the last two in chronic pain sort of things. And then you've got all of your adjuvants, which are used for neuropathic pain. Steroids, TCAs, amitriptyline is the one that you will probably most commonly see. The anti-epileptic like gabapentinoids, which is gabapentin and pregabalin, those ones are quite common as well. And the SSRIs and SNRIs you don't really see too much in pain. It's a bit of a last ditch effort, okay? But they're your sort of broad classes. And the reason you have to sort of know those is something I'm not going to tell you about. Yeah, so routes of administration is, the principles in general of analgesia. So should be chosen wherever possible. Oral administration, yeah, exactly. So ideally, you want everyone on an oral tablet. So the less that you can give IV, the better. And that's with regards to everything, I guess. With regularity, I would obviously advise you don't have to know the pharmacodynamics and pharmacokinetics of every drug, but have a rough idea of exactly what it is you're giving and why you're trying to give it. There's no point giving paracetamol as a stat dose and hoping that it's going to do anything. So give someone paracetamol and ibuprofen for a long period of time and get them to take it regularly, and it will build up in their system and actually help them. Whereas oxycodone you can give as breakthrough medication. So that's all I mean by being aware of those. Be aware of which ones you can give regularly to get their effect and which ones can be given as a breakthrough. Okay. Evaluation of intensity, this one's always a really difficult one, and that's how much pain is someone in. So the safe answer, and the one that we all should practice by, is that they're in as much pain as they tell you they're in. And more often than not, how much they say they're in and how much you think they're in probably approximate fairly well. Sometimes you do get, and people talk about it a lot more than probably is true, but you get this sort of either drug-seeking behaviour or the old man, in fact it's generally a young man post-op that's in a lot of pain that's really excessive compared to what procedure they've had. I would suggest that just treat them the same. Like, at the end of the day, my opinion, and again, this is all my opinion, but who gives a fuck if they get a bit of extra morphine with you, really? Like, if what it means is that for every 5 that are in fact getting the drugs that they're seeking, you get another 5 that you're treating properly, so be it. That's a good enough trade for me. When they get out of the hospital, they're not going to get it. So, who cares, okay? Dosing, just be aware when you have really big people that some medications are going to be dose dependent. So obviously things like paracetamol and ibuprofen are going to be pretty standard for everyone. You never exceed the dose. But when you get really small people, you actually go down on the dose of those as well. So don't give 4 grams a day of paracetamol to like a little old man that's 50 kilos because you might push him to liver failure. So you downgrade that dose and only give it, say, 3 grams over TDS instead of like 1 gram TDS instead of 1 gram QID sort of thing. Okay. The other one is then with a lot of the opioids that they will be relatively, in some ways, body dependent. So bigger people will be able to tolerate the side effects more and therefore get more action out of them, rather than a smaller person who might not tolerate the side effects as well, specifically hemodynamic side effects. Okay. And review is the last one. So it's really easy to just put someone on medication and let them go, but you do have to keep an eye on exactly what they're on. Regularly review it. Once a day is fine on a ward round. Have a quick look over and see, do they still need all of this stuff? And the way that you make those decisions is the analgesia ladder. So this was designed by the World Health Organization in 86 or something. And it was initially just 3 steps. They've added a 4th one in recently. The way that it works is if you have an acute pain syndrome or a chronic pain where something's gone bad, like an acute increase in it, you basically start at the maximum therapy and work your way down as they become tolerant. If you have, on the other hand, something that is a chronic issue or it's like a cancer pain related, you start at the lower end and work your way up as they need it. Because the idea is that the acute ones are going to get better once you get on top of them. The chronic ones are only going to get worse and you want to find their lowest stable point. So you always start with everyone paracetamol, ibuprofen. Always, whether you put people on codeine straight away, so Panadeine Fort, or whether you put them on tramadol, depends on often either the pain service team or what the registrar likes. And then you move into your opioids as well. So give things like Tarjan, so the long-acting combination of oxycodone and whatever else it's with, I can't remember now, naloxone maybe. So you give that couple of times a day, twice a day, and give them breakthrough oxycodone. That's quite helpful, and all of that's oral, so it makes it easy. A lot of the other ones, like the neuropathic pain things, people tend to throw them in there when they're not getting on top of it. Doesn't really help if it's not actually a neuropathic pain. But having said that, who knows if what they're talking about is neuropathic pain or not. So if you feel like it and it's not controlled by that, you can add like gabapentin. That's one that people tend to go for, pregabalin. They're the common ones. The other ones are TCAs I would steer clear of until you get someone else. But if you had someone on paracetamol, ibuprofen, Tarjan with oxycodone breakthrough, tramadol and pregabalin, that's relatively reasonable for you to start them on that stuff. Okay? And then just knock yourself up and down the ladder as you see fit. So remove them in that order as well. There's no point in removing your paracetamol and ibuprofen if they're still on Tarjan. That just doesn't really make much sense. Okay? Urine output. So I'll try and keep this relatively short. It's obviously a huge topic about polyuria and oligoanuria. But the thing to remember is that, at least for polyuria, there's not really a strict definition, so people throw around the term a lot. If it's greater than 150 ml an hour, or greater than, say, 3 litres a day, I would call that polyuria. There are lots of different causes for why, like page of causes, so don't bother necessarily knowing them all. The ones to be aware of that you will see, and I sort of talk about this outside of the ED presentations, more just in the patient that's in hospital that you know about already. Pretty much the number 1 and 2 cause and 3 cause is going to be inappropriate diuretics. After that, you then get your excessive intravenous therapy. So someone that hasn't really worked out their body weight is giving, 50-year-old grandma 3 litres a day. Uncontrolled diabetes is relatively common. And I guess the other one, UTIs and renal tubular acidosis, that stuff is starting to get a little bit more down the list for causing this persistent polyuria, but it is possible. And really the way to fix this is to find whatever's causing it and treat it. So it's not really about stopping the polyuria, like putting a plug in there or something, or necessarily giving them extra fluid unless they need it because of hemodynamics. In terms of what you do when someone says, oh, we just checked this patient's fluid chart and they put out 4 litres yesterday, once you've confirmed that it's true and that sort of stuff, you do a bit of a scattergun approach of bloods, UECs, urine electrolytes and creatinine, and then the urine and serum osmolality, as well as BSL for diabetes, and make sure they're not hyperglycemic, full ward test in case they do have a UTI that could be causing it, and a VBG which gives you your acidemia or your potential for renal tubular acidosis. So that sort of covers your common ones. Right? You start someone on strict fluid balance, so if someone says they've got polyuria for 24 hours, then they need a catheter. They might not have one already, they might have been doing it in a pan, but they need to have a catheter in. You don't need to give them, like we were saying, bolus IV therapy to actually match any sort of urine output, the exception being in a post-obstructive diuresis. So everyone else, don't worry about it. If they're hemodynamically okay, treat them like any other normal patient, doing your fluid assessments, doing all that stuff. In post-obstructive diuresis, which is the domain of pretty much urology and urology alone, they will tell you, and again, every registrar/consultant will have roughly their own criteria, but generally greater than 200 mils per hour, and you have to replace a portion of that in the next hour with IV therapy. There are rules about how to do it. If it's within the first 24 hours, then you replace half of what came out with 0.9%. So if they dump 300 mil 1 hour, the next hour they get 150 mil bolus of saline. If the hour after that, they then go another 250, then they get 125 mil of bolus. So you're sort of always catching up a little bit. Okay. After 24 hours, if they're still in post-obstructive diuresis, then they end up, you try and tailor a day's worth of fluid into what they've lost. And again, there's rules about it, but each registrar will have their own rules. Just to keep aware or keep in mind that that's the only one you have to actively replace without necessarily knowing their hemodynamic state. If they're in fact unstable, then you fill them more. But that's your bare minimum. No matter what, they get that. Okay? The opposite side is oligouria or anuria. So oligouria is less than 0.5 mils per kilo per hour, and anuria is less than 50 mils per day. So causes are pretty broad that you'll have to be aware of. It's pre-renal, renal, post-renal. Post-renal is obstruction, so anyone that has it, you can potentially consider scans. So anything from ureter down. ureteric scan, urethra. You don't really scan it with an ultrasound, but I guess you could consider doing like a retrograde cystogram or something if you're really interested. But generally, you'll know about an obstructive cause. Post-operatively, the most common ones are going to be some form of fluid loss or adrenal cortex stress, and all of those are normal physiological responses. So in some ways, it is expected to see a little bit of oliguria, and what you look at is trends. So you don't respond to 1 hour where their urine output was 20, although if they've got a catheter, you can be a bit more comfortable about that. But you try and respond to trends, so over a couple of hours, see how it goes. The way that you can do it, check their bloods. All you're really looking for in an oligoanuric patient is their creatinine and their urea. If their creatinine and their urea are doing okay and they're not trending off worse, then at least you're sort of, in a very broad way, ruling out a renal cause, an intrinsic renal pathology. If you think that it's a pre-renal issue, you can give them a bolus. So you can give them 250 to 500 ml of fluid and see what happens to their urine output in the coming few hours. The other thing you can do is a small dose of frusemide, and that also helps in conjunction with your creatinine and urea to see if the kidneys are actually working properly. So it's not really going to make the kidneys do better, but it will tell you if they've got ability to actually produce urine. Okay? And this is the same as previously, strict fluid balance. So catheter in if they don't have one. Everything that goes in, whether it's oral, IV, food, gets written down somewhere so you can assess it. And these sort of people you can look at every, I'd say, when they first become oligoanuric, maybe check them again 6 hours or end of your shift, start versus end of your shift. And then they need to be checked relatively quickly because you don't want someone going into renal failure on the ward. Okay?
Then would you only do a bladder scan if you examined them and you thought there was...
So what is a bladder scan going to show you?
If they're in retention.
Yep,
They
okay.
are.
Yeah, so
Well, there might not be, like, if they're
what sort of cause will it show you?
an obstructive
Yeah,
post-renal.
Post-renal. So yeah, you can do that.
Yeah.
It's common enough. It's sometimes not very specific.
Yeah.
Because depending on what sort of patient they are and how big they are and what else is going on, it might be difficult to find.
Yeah.
But it is, yeah, definitely, it's worth asking for, and at least using it as one of the other many factors that you use in making a decision. And I guess the last thing to talk about, this was quite quick, some people did ask about, I didn't really want to talk about this, but about the non-necessarily medical side of things. And fair enough, I guess it's worth remembering that even though you're doing internship, you're not actually going to be an intern for the rest of your life. Your goal is to be probably something more than that. So it's worth thinking early about how to get to that stage. So the sort of way that things I suggest you look at is training programs primarily. You won't know what you want to do. Some say they do, sure, but generally you won't really know. So you want to get an idea of what you might like doing, have a look at some of the courses and their actual prerequisites for each one, because it helps you pick rotations. You can also then pick your rotations based on what you think you might like. So if you think you like renal, try and get yourself a renal medical rotation. And you can see what the lifestyle is like, as well as the medicine. It's quite easy when you're young to focus on the medicine, and like I'm like a year older than you guys, so it's not much of a difference. But it's really easy even for me to say, oh, I love ICU and I'm going to do that forever, and not consider the other ramifications like your lifestyle and everything else. So I really would take advice from some of the registrars that are going through the training programs, and even more from the consultants that are at the other end, where they've now had that experience for 15 years and they've probably gotten over the initial awesomeness of doing a suture. And then they're like, okay, is it good for my lifestyle? Again, personal, but I don't really put job opportunities into that category though, because quite frankly, someone's got to get a job, so it might as well be me, right? And I'm sure that most people think like that. So I'm always a bit wary when someone says there are no jobs. I'm sure there aren't, it's going to be low, but someone will do it. Long hours, again, can sometimes be a little bit not just subjective, but changes. So other than some of the surgical specialties aside, where the long hours are relatively self-imposed as a consultant, every registrar has long hours. Like that's what you do as a registrar. It's a relatively crap job. Sometimes you don't enjoy it, and you're there all the time. Okay, so you just deal with it. Courses and conferences, I would recommend signing up to some early courses in particular. There are long wait lists for courses, like 1-2 year wait lists at least. and you need to be a medical practitioner when you sign up. So once you graduate, sign up. And sign up for everything. You don't have to pay for it. You don't have to do it. If you sign up, then you get the opportunity to do it in a year and a half down the track. And for all you know, you might be